CSB3464, and I am Louise Bull. My name is Louise Bull, and I am in my final semester as a paramedic student. Today I'll be reflecting on the importance of interprofessional communication using the 5R model. While no specific definition for interprofessional communication exists, most of the literature referred to it as a situation when professionals and the community communicate together in an open and collaborative and responsive manner. Generally, quality verbal communication consists of establishing rapport, verbal and non-verbal cues, and eye contact in order to communicate information in a timely, accurate, and a safe manner. Specifically, I would like to focus on clinical handover and how important that is for achieving the best care and outcomes for our patients. And the thinking point is, do we achieve this effectively as paramedics? So what is interprofessional communication? Interprofessional communication is a foundation skill by which paramedics ensure the best clinical outcomes for our patients on arrival at the hospital, but also in which we communicate with each other. We use it on a daily basis. We speak to our colleagues, dispatchers, to patients, relatives, GPs, physicians, and of course to the triage nurses. As student paramedics, we have witnessed firsthand the autonomous, dynamic, and stressful nature of our role and the impact that it can have on care delivery. That's the theme echoed throughout the literature. Successful interpersonal and professional communication between healthcare staff is crucial for safe and effective collaborative patient care. Funnily enough, poor interprofessional collaboration is associated with ineffective and inefficient patient care, a high prevalence of medical errors, medication errors, and lower job satisfaction. Paramedics, as we know, are under a huge amount of stress to provide succinct, direct, and quality handover in a timely fashion, usually due to the acuity of the patient, workload constraints, or just the sheer busyness of the ED that we're presenting to. There's lots of evidence to suggest that a slip-up, the smallest miscommunication, an omission, an error in our clinical handover, it has dire consequences for the patient. A healthcare study conducted on 28 hospitals in Australia showed that 11% of errors could have been prevented, and they were solely due to communication breakdown in the handover process. A collaborative approach for handover with effective communication to emergency staff dictates the direction of care that the emergency staff take. So if we focus on one part of the vital signs and miss another, the other part could be very important. So getting that handover right is super imperative to direct the flow of patient care. There are a lot of factors that influence decent, good quality and objective interprofessional communication. There are language barriers. People are so stressed. The environment is busy and noisy. As healthcare professionals, we are tired. We haven't eaten and we probably haven't peed in 6 hours. Evidence shows that handovers between paramedics and nurses are rushed and often performed multiple times in multiple different areas throughout the ED to different people, whilst paramedics are fatigued, hungry, and overworked. Giving a thorough handover to a rushed and abrupt triage nurse at 0400 hours is challenging at best, without having to relay the information 2 or 3 times to different members of staff, for example, a triage nurse, a bedside nurse, and the emergency physician. I'll demonstrate this shortly. In more recent times, it has been observed that the implementation of SBAR or ISBAR handover formats in the nursing world enable clinicians to streamline their handovers, and from a student perspective, it's easier to organise information when remembering the acronyms. Effective teams must cultivate and sort of foster these critical interprofessional communication behaviours in order to achieve efficient, safe outcomes for patient care. Barriers and enablers to interprofessional communication have been identified. The clinical environment, such as being high acuity, rapidly changing teams of nurses, work overload, and the introduction of electric communication such as IMR. 2. Interpersonal relationships, such as hierarchy, unfamiliarity, mutual respect, feeling part of a team. 3 is personal factors, fear, self-confidence, uncontrolled personal emotions, conflict management skills, which are very important. And 4, training or lack thereof. I mean, universities are getting much better at teaching the foundations for interprofessional communication. However, training is a great component of increasing our awareness of this. Professionals being aware of the importance of communicating in a team, the process becomes increasingly difficult due to professional features. Levels of education and training are different. It's a huge factor in how we talk to each other as healthcare professionals. A study which was performed in a trauma centre identified that discordance was most likely to occur with information handed over and then documented by paramedics, suggesting there's a difficulty with recall. Of interest, paramedics often record clinical notes for handover in transit to the hospital in their gloves. On scene, when they're talking to the patient, they write it down, which they discard this following handover and before commencing documentation in the electronic system. This, in combination with time lapse between the handover and writing of electronic notes and the physical distance from the patient, increase the risk of paramedics forgetting case details. Sometimes paramedics are often lined up with their patients ramping inside the ED entrance. The nurse, team CNC, or triage nurse randomly assess higher acuity patients from one ambulance stretcher to another. They receive a brief handover, categorize the patients in order of triage category, and allocate an appropriate ED bed if there's one available. The receiving nurse is constantly interrupted by other staff, doctors, wardsmen, other nurses. And this leads to increased waiting time for the paramedics and interrupted clinical handover. Patients usually do not have an identifier bracelet on their wrist while on the stretcher, and 2 or more members of ED personnel will ask people, confused people, elderly people, sometimes disorientated people, his or her name during these times of heightened activity. The paramedic responsible for the patient could be standing nearby, but is often not consulted for this information. This is a prime demonstration of how critical errors are made, especially medication errors. What we have done, or what we can do to make this better. Evidently, there's research to suggest that interprofessional socialization and training as developing clinicians, as well as the implementation of multidisciplinary standardization of handover, may improve the overall patient journey and improve patient safety and outcomes. For example, using our new iPads to improve how we relay data, the accuracy of having information in front of us ready to relay to the triage nurse on a clear system is a great way of improving this process. It records patient history, current presentation, allergies, and vital signs, and this means that there is less chance of mistakes being made. Using technology as part of a handover process also saves time and money. Clinician, that sometimes patients are listening intently to bedside handover, and they might drop a comment or correct you on the information that you might have gotten wrong. Interestingly, there's a few studies that show that the patient's role in bedside handover means that contributing to clinical information relating to their case or progress influences patient safety. This could be pertaining to the site of the injury, allergy information, and current medications. Now, let's just have a look at a bit of a case study. Close your eyes. Imagine it's 7 p.m. on a Friday night in the middle of a busy emergency department. You're hungry. You haven't peed in 6 hours. Your uniform smells like Caesar salad dressing from the lunch that you spilled down it. A stranger's vomit and sweat. It's pretty gross. You've been rushing around all day. You're tired and you're worried about your 2-hour peeing on your couch, the overdue bills that you've got to pay, and whether your daughter's gotten the chicken out for dinner. It's been a pretty busy shift on the road, and the last job of the night, an hour after you were supposed to finish, was a very distressed woman who was vomiting with chest pain diaphoresis. Typical ACS. You cruise in a bit of a rush on scene and gathers an unideal history from the patient's family member. You've arrived in ED to hand over the patient to the nurses. Your documentation isn't done yet. and your vital signs are scrawled everywhere all over a glove in smudged black ink. Upon entering the ED, it's noisy. There are security guards standing there with what appears to be a very angry and dangerous mental health patient. There are buzzers going off, machines beeping, and people crying. The corridor is packed with stretchers as far as the eye can see, with paramedics everywhere and nurses running around wheeling things, taking obs, and generally just being very busy. So I suppose we have to think about, how do these things influence our judgment as a paramedic? How do these distractions influence our interprofessional handover and our communication? Do the information and the interventions discussed adequately address the shortcomings of interprofessional communication? Well, interprofessional communication is the backbone of what we do as clinicians. It affects our patient safety, it affects the way we speak to each other, and it affects the care that's given to our patients. By utilising the methods that we've talked about today, we can develop as clinicians. We can hone our skills and the ability to talk to one another as healthcare professionals.